The views and opinions expressed on this program are those of the participants and do not reflect the views of BronxNet or the program underwriters.
BronxNet. Your voice, your views, your vision.
Good evening and welcome to BronxTalk. Tonight's guests contend that there are wide disparities in who gets quality health care and who does not. And those disparities, they claim, are determined by how you pay for your health care. For example, are you a Medicaid patient? Do you have private insurance? Do you have no insurance? Rather than medical needs or available resources, these factors, they claim, determine the quality of health care that some people receive. And they say it often leaves people of color at the short end of the stick. And these are not little problems because, our guests claim, this scenario has contributed to serious illness, higher healthcare costs, and even death in some cases. So let's get into the notion of healthcare disparities. We'll define it and even see if there are some solutions. You too can weigh in with comments or questions by calling in at 718-960-7241. You can also email comments to us at bronxtalk@hotmail.com, and we'll read those on the air during a future edition of our program. But for now, please join me in welcoming the Project Director of Bronx Health Reach, Charmaine Ruddock. Good evening. Thank you, Ms. Ruddock, for joining us. And the Director of the Health Justice Program for New York Lawyers for the Public Interest, it's Shana Elrington. Good evening, Ms. Elrington. Thank you for joining us. Let's start with you, Ms. Ruddock. Let's define, I said we were going to define it, let's define health disparities as you folks see it, and why are we even having this conversation tonight?
So health disparities can easily be defined as the health outcomes of people of color versus people who are white. And for the most part, we have found the data supports it. It's one of CDC's primary issues that people of color live sicker and die earlier than other people. And when we say people of color, we're talking African Americans, we're talking Latinos, we're talking Native Americans, we're talking Asian Pacific Islanders. The data is there, and CDC, in trying to grapple with this, has since 2000 had a program called REACH, Racial and Ethnic Approaches to Community Health, that sought, even when it was trying to address the health outcome of all people in the U.S., that particular attention be paid to narrowing that disparity gap that people of color had versus people who are not people of color.
If you look at income level immediately, and this isn't a very sophisticated view, you could simply say, well, frankly, people with fewer resources to get health care, people who may be higher on the unemployment rate and all those kinds of factors are naturally not going to have the resources to have access to health care. So that one easy answer would be, well, you know what, it may not be because of that kind of health system, it may be simply because that's the economic structure, unfortunately, that we're in. What is your response to that?
So definitely there are what folks who have studied this call the social and economic determinants of health that do play a large role in racial and ethnic health disparities. However, there have been studies that have shown even when you took insurance status, even when you took into consideration education, income level, that in many instances you found disparities existing in people of color, even when you took those into consideration.
Well, then we have to dig a little further and say, well, then why is this so? Assuming what you say is true, that if you take those factors out and yet they still are not as healthy and they're still not receiving the kind of health care, why, in your estimation, is this so?
Well, folks who have studied this disparity will talk about sort of the stress factors that are involved. There is one particular study that I think struck many of us when they looked at college graduates, African American women, and found that they suffered, the infant mortality rate that they suffered was higher than white women with a third grade level education. So we have all of those factors that we have to pay attention to. But for Bronx Health Week, we really have looked at the healthcare system, particularly access to specialty care in our academic medical institutions and private teaching hospitals here. And we have really paid attention to that because even when we look at it, insurance status plays an important part in how people are put into two separate systems of care. And for us, when we look at who are the people who are not getting the quality care, the people who are on Medicaid or the people who are uninsured, we see that the people in those categories are disproportionately people of color in New York.
Somebody goes into an emergency room and they have an ailment of some sort. How does this play out for that person so that they get, as I called it, the shorter end of the stick, or as you say, maybe it's called segregated health care? How do they get treated differently than, frankly, someone that comes in with the color of my skin?
Well, with the emergency room, there may be something of a difference because there are legal requirements where people have to be triaged. But one of the things that really we are paying particular attention to is when those people who maybe got seen in the emergency room need to have follow-up care, right? There's some specialty that they are required to see because of the condition they were seen in. If they're referred to a specialist at a private teaching hospital, the first thing they're going to encounter, as we all encounter when we call for care, is what insurance do you have? If they say they have private insurance, meaning an Oxford, a Blue Cross Blue Shield, and Aetna, they're going to be directed to see the doctor in his private doctor's office, or what is also called the private faculty practice. If, however, they say they have Medicaid or, God forbid, they're uninsured, they're going to be directed towards the clinic. And the care that occurs in those two settings look quite different.
We're going to bring Ms. Elrington into the discussion in a second and talk from a legal point of view. So what you're saying is if you come in with a certain type of insurance, that determines in large part how you get care.
Yes.
So it would seem to me that it's literally the administrator sitting at the desk who makes that judgment. Okay, so you go to that line and that line?
Right. So I call, I say I have Medicaid. The person answering the call, the front desk person, will say, okay, I will send you to the clinic, or these are the hours and these are the days that the clinic operates where you can be seen.
And this would be a clinic within, and the private hospitals, I mean, I know that you don't want to declare war on any of the hospitals, but
right.
Just to define it for the public, the private hospitals would be, let's say, Montefiore in the Bronx.
Right, New York Presbyterian, Mount Sinai, right.
Some of those, as opposed to the city hospital.
Exactly, as opposed to our HHC hospitals.
When I began to prepare for the show and first read about this, and I was thinking about it, I said, can this be legal? It would seem that if you have an ailment, you deserve to get the best possible care, regardless of what your insurance is. And it also, I'll piggyback the question with, it's disturbing to me that it's not a physician making the recommendation, but it's actually an administrator, maybe even a low-level administrator making that determination. Is there a legal issue here that should be dealt with?
Well, there are a couple of legal issues. As Charmaine mentioned, if you have Medicaid or you're uninsured, you're walking to the clinic. You're going to get an appointment in the clinic. But if you're privately insured, you're going to be steered into the private faculty practices. In New York, the Medicaid and uninsured population is predominantly African American and Hispanic, overwhelmingly so. So at some of these institutions, the clinic and the faculty practice doors are right next door to one another, and you literally see people of color going through one door and people not of color going through another door. And so
this sounds almost like from pre-Civil War times.
Exactly, and that's why we call this issue separate but equal segregated care, right? And so for a legal standpoint, really these discriminatory steering practices violate Title VI of the 1964 Civil Rights Act, which basically prohibits any recipient of federal financial assistance, like a hospital, from discriminating against someone on the basis of race or national origin. So when they steer people in this way, and that steering practice has a disproportionate impact on African Americans and Hispanics, it likely violates Title VI. And so that's one of the legal claims that we've advanced.
Can an individual simply say, wait a minute, you sent me here and I really wanted to go here?
Yep.
Can the individual bring a suit? Has that happened?
So unfortunately, under Title VI, there's been a tremendous sort of backlash against the expansion of civil rights, and there's sort of been a narrowing. A private individual can't sue under Title VI because of a recent Supreme Court law. But what they can do is take the complaint to the Attorney General or someone who's responsible for enforcing the state's law and try to bring a suit
so
that way.
They can't, that's a very interesting distinction. They can't like say, okay, well then I'm going to sue you and bring you to court.
Right, not under Title VI, but of course you always have the freedom to file an administrative complaint and sort of raise the issue in that way, but under Title VI, no.
From a realistic perspective, from the perspective of hospitals or other providers, can't we just simply look at it in two ways? Number one, we just don't have the resources, and if somebody is going to come and use our best facilities, for want of a better term, or use these facilities, we've got to have that paid for, and the money is not coming certainly from someone who's not insured, and it's also not coming in equal portions from Medicaid. Can we understand their dilemma and saying, look, we'd like to provide it, but you got these large numbers and we just can't serve them. If you force us to do that, you'll have chaos.
A couple of responses, and this is definitely a concern that we've heard raised from the hospital side, the provider side before. First of all, we can't look at Medicaid reimbursement rates sort of in a vacuum. I think a lot of people knock Medicaid and sort of say that the payer rates are very low, and in some instances they are, but actually in New York State, they've raised those rates for ambulatory care visits such that it's higher than even private insurance. And then on a whole, the reason why teaching hospitals and facilities can exist is because they get a tremendous amount of money from the federal and state government because they care for Medicaid patients. I think New York State got something like $2.5 billion last year in graduate medical education payments. And so it's not that you're just getting a small rate, Medicaid rate to pay for these patients. There are all sorts of funnels, different streams of money that come to sort of pay for it. So we can't explain it just alone by that system. And then in addition to that, there's the whole, if a patient can't access the care that they need, they can't get the quality of care that they need, then they end up in the emergency room, which we all know is tremendously expensive and the most expensive point of care.
Are these clinics, I don't know, maybe Ms. Ruddock, this is a better question for you, are these clinics within the teaching hospitals, or are these clinics like, elsewhere? And then I'm going to follow up, depending on how you answer that question.
So they can be both. They can be both within the very grounds of the teaching hospital. As Shana said, sometimes they're side by side. Sometimes they're even in the same place, but just different hours and different dates. And sometimes they're outside. However, they are that teaching hospitals. They belong to that teaching hospital, whether they're on the grounds or outside.
So then here would sound like, I'm going to solve the problem for you. Why not just wipe the notion of the clinic away and just have all those resources available and everybody shares all the best doctors and the quote-unquote worst doctors or the same facilities? Wouldn't that be a simple solution? Why do we even have a clinic versus private care?
Right. I mean, that's our
Are you ready to vote for my idea here? I'm not running, I assure you.
That definitely is our recommendation, that irrespective of your insurance status, patients be seen in the same setting, treated by an integrated team of providers, meaning their residents see them as well as the more seasoned doctors, the board-certified doctors, that they have access to the same sort of technology, that the private physicians, that everybody has the same high quality level of care. That is our recommendation to these hospitals and even to the Department of Health. Right. Because I think, as Shana pointed out, the funds that are spent for the Medicaid, for the reimbursement of Medicaid patients in the clinics are actually quite attractive versus what's spent for the same patient if they're seen in the private doctor's office. So it makes sense to say, okay, with all that you're funded, let's see them in this integrated setting.
Is there a pushback if you and I were to walk in and knock on the door and say, hey, why don't we do it this way? Is there a pushback or a reason why that's not being done? And I'd like to think it's pure racism is not on the table. I'd like to eliminate that.
Right.
Is there a reason why that is not being done?
Do you understand?
I mean, so there are a couple sort of reasons that we've gotten before. The first is sort of that's just the way things are. We've always done it. So there's sort of
I hate that answer. Sorry.
There's some inertia there. We've gotten the cost argument that you sort of raised before. We've gotten people saying that this is just really hard to do. And sort of one of the more disturbing things we've heard is that our private insured patients don't want to sit in the same room as our Medicaid and uninsured patients.
Dear whoever.
And the other piece that we've
Disturbing,
heard,
I'm so sorry.
the other piece, just to add to what Shana said, we've heard that hospitals are fearful that those private faculty physicians that they have attracted will go elsewhere.
Will not want to go if they
will go elsewhere, and so they will be poached by others. Now, our response to that is if there's legislation that requires all hospitals, all private teaching hospitals to have this new setting where all patients are seen, then there is no incentive to go elsewhere.
And of course, all doctors take the oath, and we know that they're supposedly going to serve whomever is in front of them. I've read a number of anecdotes and some of the videos and things explain, but maybe you can help illustrate to our viewers how this works. And I mean, I said some things at the top of the show that this can be a very difficult situation. How does it play out for somebody who gets caught in this web in unfortunately the worst ways?
So as we said, there are two separate systems of care. If you're seen in the private doctor's office, you're going to be seen by that same doctor for the length of the course of your treatment. That doctor will confer with your referring doctor. That doctor, if you need to be seen after hours, you call, you'll get that doctor's answering service.
Of course, sure.
You will speak to that doctor soon after. So we're talking about continuity of care. We're talking access to care, access to that doctor after.
Give me an example of for somebody who doesn't get that care, a case study, let's say, or somebody you know of.
So if the person is on Medicaid or is uninsured and they get seen in the clinic, they're going to be seen by the residents or the interns.
I understand, yeah.
Those residents or interns are rotating, say, every 3 months. So there goes continuity of care. And what we hear time and time again by our coalition members, by community residents who end up in that, is that they're always having to tell the new doctor what the situation
Start from
is.
scratch.
It's starting
They
from
don't have
scratch.
a simple medical record that
And
passes.
sometimes it's sort of a matter of life and death, right?
Right.
So someone will come in and sort of complain of abdominal pain, go into a clinic, see a resident, and the resident says, you know, you have indigestion, sort of go home. The person still has that. A couple weeks later, goes in, sees another resident, has to explain it over and over again. And we've had a coalition member who went in and did that over and over, and then it turned out she had cancer. And it was sort of a year after her initial visit, initial contact with the system.
And it might have been with a more sophisticated...
Or an integrated team or the
specialist.
same doctor who sort of saw her again and again and again. And it's sort of a matter of dignity for the person who feels as though this system is not respecting who they are and not giving them the rights that they're entitled to. And it can mean, you know, life or death.
That's as an unfortunate example of how this works or doesn't work as we could get. Is that Valerie, I'm so sorry. Valerie from Morris Park is calling in. Valerie, how are you this evening? Do we have Valerie? Maybe we don't have the button pushed.
People who get Medicaid, but
go ahead,
can't
Valerie.
afford
Talk to us.
insurance do.
Say it again.
Hello?
Yeah, hi.
Okay, so what should people who can't get Medicaid but can't afford private insurance do?
Do you have your TV on? You need to turn the volume of that TV down. Simple matter. You want to try again, Valerie? Otherwise, we're going to let you go. All right, we'll come back to her. Give me some numbers. Ms. Ruddock, what's the size of this problem? Do we know how many people have been caught in this circumstance, or?
We have a very large Medicaid population, a very large uninsured population. And those are the numbers we're talking about, particularly when people, we've done a very good job in New York in terms of primary care. We bump up against when we have to refer people to specialty care. One of the things that we are really concerned about is with the Affordable Care Act and healthcare reform, with the expanded coverage, with more people being put on Medicaid with new insurance. You will have those people expanding the roles of Medicaid, but coming up against this bottleneck when they try and access specialty care.
Legislation. Let's talk about legislation. There is legislation on the table proposed by 2 Bronx legislators.
Yes.
I can go through it, but why don't you explain it
so
our viewers know what it is?
Introduced last year, and our 2 sponsors are Assemblyman Nelson Castro and Senator Gustavo Rivera. And basically the bill wants to ensure that all people receive access to high quality care. And so essentially it'll prohibit hospitals from steering patients into the way that Charmaine described. And it also has a couple other pieces that require that patients be seen by an integrated team of physicians, and also that hospitals make best efforts to participate in Medicaid managed care plans. Because one of the things we found when we were doing research was that a lot of times people were enrolled in certain Medicaid managed care plans that the hospitals didn't accept.
What are the prospects? And again, your presentation to me sounds totally logical, but of course I never seem to know. How does it fare out there? And I could certainly see others saying some of the things that I raised earlier. We can't afford to do this. You're asking institutions, large institutions, to make large expenditures, and that will do worse for our system than what we have now.
Right. I think more people agree, more administrators, more hospitals sort of agree that this issue is a real issue and that we're sort of not grasping it from out of thin air, but we understand that it is a very difficult issue for a number of reasons. And we've been working on it. REACH has been working on this issue for over 12 years. And so we're going to keep on pushing and keep on doing whatever we can to push this legislation and push this issue.
So we don't know yet where it's at. I guess you're
so we're
all
right.
right, we're going to try Valerie again. Valerie from Morris Park, are you there?
I'm here.
Hi, Valerie. Now we'd love to talk to you.
Hey, okay. Sorry about that.
That's okay.
My question was, what should people who can't get Medicaid but can't afford private insurance do?
Slightly off the track, but it is a very, thank you for the question, a very reasonable question, and thousands and thousands of Bronxites are in it. What do we do?
So are you talking about, I'm assuming she's talking about people who end up being uninsured.
That's where we're going, yeah.
And in a lot of ways.
Especially people who are unemployed, and it becomes a very difficult problem.
And I think it's an excellent question, and quite disturbingly, sometimes they just aren't able to access the care. They call to make an appointment at these facilities, and the facilities say, well, there's no one here to sort of take care of you, and then the person just sort of disappears into the
so
ether.
A person like that would, I would recommend, and we've done a number of shows on it, is Family Health Plus and Child Health Plus, depending on who might be in your family. You can access that through various managed care organizations.
I would also add that the Institute for Family Health, that's a parent...
Oh, this is a great See, she had the answer.
The Institute for Family Health, that's a parent organization for Bronx Health Reach, is actually a federally qualified health center, and by that designation, we'll see anybody. Anybody can come in. Your insurance status will not prohibit you from being cared for. So I would encourage her to go to any one of those federally qualified health centers in the Bronx.
So while it's not necessarily an answer about her health plan, because if she's listening to this show, she's saying, wait a minute, I don't want to be in this category. I'd like to be in another category. At the moment, there doesn't appear to be an answer, but one of the answers is the Institute for Family Health.
Right, has several health centers.
As in the Bronx.
In the Bronx, right.
And so I know Jane has some contact info, and that can be accessed. We can put that up on the screen.
And,
so that would certainly be one answer.
And hospitals are also required to provide financial assistance to people. So there should be financial assistance policies at some of these facilities, at all of these facilities, that will help people sort of who can't afford it.
Yes, but now this brings up another whole, and thank you, Valerie, for the question, because you've opened up a whole other thing. We've talked about it from a global perspective on how to correct various systems, but what do individuals in the Bronx do now that we've educated them? Wow, you may not be getting the best care, and they realize, well, wait a minute, I'm in this circumstance. Madam Attorney, what do we do? And you've also educated us that they can't individually sue.
Right. At least,
how do they get themselves and their families out of this circumstance so they get the best health care that they deserve?
Yep. So I think that there are a couple of things that they can do. They can absolutely contact any one of us to sort of help, so that we can help.
We will have those contact numbers all through the rest of the show. Okay?
Yeah, and I think depending on the nature of the complaint, they might be able to make an administrative complaint, and there are tons of sort of legal services organizations out there that are willing to help.
Okay,
Yeah.
but they could, and Jane, let's get the number for Ms. Erlington's organization. That would be great. Go ahead.
We should also add that we have been educating folks in the community about how they can advocate for themselves and their family, and it's quite within their right.
Exactly.
If they're being seen by a resident or an intern to say, I want to see the attending, and it's legally their right to ask to be seen by the attending. Many people don't quite realize that.
We've done a number of shows from an individual perspective, that somebody walks into a doctor's office and either because of their gender and as well as maybe their ethnicity, they're told different things than other people are told. And hopefully people are a little more sensitive to it. But they may not even be aware, hopefully until tonight, that they're not even getting access to the doctor they want previous to that whole dialogue. So now, hopefully, we can help to create a more learned consumers. I think that's important. So let's just get some contact info. So people who are listening to us and saying, wait a minute, I don't want to be in this situation. I want to get the best health care for my family. How can they access you or participate with you to help change the system and also improve their own situation?
They can definitely call us at 212-633-0800 extension 1232, and they can also call our friends at New York Lawyers for the Public Interest.
And you can call out some of that contact info
so it's
as well.
212-244-4664, extension 315.
I guess I'll give you each a whack at this final question. How do you think this is going to go? I mean, I know that we've already laid out what we'd like to see. How do you see the steps for correcting this circumstance?
We think we're at a much better place than when we started 12 years ago. The fact that we have legislation passed a few years before we actually formally filed a complaint with the New York State Attorney General. We don't see this as something that has necessarily to be adversarial with the hospitals. We see the possibility of being able to sit down with the hospitals, maybe facilitated by our political leaders, and say, look, there are some things that can happen
be
right
done.
now.
Let's be aware
yes.
of it. And for you, a quick yes or no. Legislation is a big part of it.
Yes.
Because you can force them to make these things happen. Thank you both for joining us, Charmaine Ruddock and Shana Elrington.
Yep.
I appreciate your time.
Thank
Folks,
you.
if you have further comments or questions on anything you heard on tonight's show or anything going on in the Bronx, and email them to us at bronxtalk@hotmail.com. We'll read those on the air during a future edition of our program. Archives of the show are available at bronxnet.org. You click Bronx Talk on the right-hand navigation bar. Also, please become a fan of Bronx Talk on Facebook. Next week, how about this? Senator Gustavo Rivera will join us. We'll talk to him about this as well. Then the week after, April 9th, we'll go into the Assembly, and it'll be Assemblyman Jeffrey Dinowitz will join us. Bronx Talk, Monday nights at 9 on BronxNet, Cablevision 67, Verizon Fios 33. Thank you, of course, to Jane, our producer, Michael, our director, Dina, and the cast of thousands around us, and to you, good night.
I'm lucky. Let me help you with that. I get to do something I love. It has nothing to do with touchdowns or titles. Everybody bring it in. I get to play a part in the life of someone just starting out. How many of you think homework is just as important as teamwork? I help keep kids in school. Good. And that's the name of the game. My name is LaDainian Thomason. I don't just wear the shirt, I live it.
Give, advocate, volunteer. Live United.